So the dialectics in dialectical behavior therapy is, to be dialectic means that two opposing ideas can both be true at the same time, right? And a good example of that is the temperature in the room. I'm going to guess that people in this room, some of you are chilly. I know I'm always chilly. Some of you are chilly. Some of you are probably just right. And somebody probably maybe is even too warm, right? So who's right? Is it too warm? Is it too chilly? Or is it just right in this room? Anybody have a guess?
Everybody.
And why is it everybody?
Because it's subjective.
It's subjective. It's my experience of it is as valid as anybody else's experience of it, right? My experience of the temperature in the room, whatever it is, right, 69, 70, somewhere in there, is that it's a little chilly for me right now. Another day I might not be chilly, but right now it's a little chilly for me. For some of you, it's just right? Your experience of it is as valid as mine. And even though those two ideas are opposing, they can both be true at the same time, okay? So what we know is that change occurs in the context of acceptance of life as it is. Change occurs in the context of acceptance of life as it is. So in order to be able to remove my hand from a hot stove, I first have to accept that I'm touching something hot, right? I can't be in denial that I'm touching something hot before I can remove my hand. And we're going to kind of see a fun video on that in a little bit. And this is a dialectical concept. Acceptance creates the possibility of change, right? My hand on the hot stove. And change requires and leads to acceptance of life as it is, okay? So that's a dialectical concept. And so we talk about in DBT what we're doing in any session and in any interaction with family members or our patients is we're balancing acceptance of life as it is and change, how to deal with life in ways that are more effective, okay? Get us what we want more often in ways that aren't harmful to ourselves or other people, okay? And so what you'll hear a lot if you are ever have the opportunity to do a consultation team, you might hear us say, maybe you need to lean in on acceptance more, which in DBT language is validation, right? And validation is that thing where we go, that makes perfect sense. Of course you feel that way. Anybody would feel that way in that situation. Or it's the me too. I hate when that happens, right? So maybe you need to lean in more on validation, the acceptance part. Or maybe you need to lean harder on change, right? If your patient is really perfectly comfortable with you soothing them, right, that probably means we're leaning too much on acceptance and we need to lean harder on change. They need to feel some level of discomfort to have the motivation to want to change the way they're doing something, okay? We have 4 skill modules that we teach. Mindfulness skills and emotion regulation skills, which I'm going to give you guys examples of skills to take home with you in your practices, are the acceptance skills. That's when we lean in acceptance, we're using those skills. And then the skills that are change-oriented are our distress tolerance skills, which are distress tolerance skills and interpersonal effectiveness skills. So distress tolerance skills are, how do I get through this difficult situation without making it worse, right? Because we can always make it worse. We bump into things in our lives that suck. They're hard. And we can make it worse, almost always, right? And so distress tolerance skills aren't skills that say, I never want to experience distress, right? That's not effective. Everyone's going to experience distress. It's how do I get through this and not make it worse? And then interpersonal effectiveness skills are how do I get what I want and need from others in ways that are more effective? Because we all know our very emotional clients or our borderline clients or borderline-esque clients, we know they do a lot of polarization, right? If you say no to me, I'm going to kill myself, right? They're trying to get a need met, and it's probably a valid need. But the way they're going about it is so off-putting that it ends up getting them the opposite of what they want, which to me is an example of making it worse, right? So when you look at DBT from 10,000 feet, which is a saying that our CEO says a lot at Willow Springs, is the view from 10,000 feet, our patients on this side of the table have high emotional vulnerability. And this is the hardwired piece that I hope I alluded to in the beginning. I tried to allude to that in the beginning. And so what that looks like is a very high sensitivity to emotions, right? They feel emotions more intensely than other people do. And if we had the nice bell curve here, they're going to be the outliers over here on the emotional side. Right? They experience emotions very intensely. And they have a high reactivity to emotion, right? And what that means is that if you can imagine having a vise on your finger, okay? And it gets tightened every 30 seconds. Every 30 seconds, it just gets a little bit tighter, okay? And right now, we're at a 5 on the pain scale, 0 to 10. We're at a 5. So we have some discomfort going on right now. At what point, with the turning of the vise every 30 seconds, at what point do you become willing to cut your finger off? Is it a 7? Is it an 8? Because at some point, we are going to be willing to, this vise isn't coming off and I can't take this pain anymore. I'm willing to do something really drastic to get relief from my pain. That's at high reactivity. Our borderline patients have an intense amount of emotional pain, an intense amount of emotional pain all the time, all the time. They wake up in the morning on the pain scale for emotions, we're talking about emotions, at 5, right? And then they bump into things in their life, and they're at a 10 before they even walk out of the house sometimes. Right? So that reactivity comes to the fact that they're in so much emotional pain so much of the time, and they need relief from it, okay? And then they get stuck in their emotions for a long time. So we know it takes about 7 to 9 seconds for an emotion to fire, peak like the wave of an ocean, and come down on the other side. 7 to 9 seconds on average. For people who have high emotional sensitivity, their emotion doesn't peak until much higher than probably most of our emotions peak. And then it stays for a really long time. So they not only get up to a 10 pretty quickly, but they stay in a 10 for a really long time. Okay. Again, that's where a lot of this emotional reactivity comes from, is the ways that they get relief are so self-destructive in themselves, it causes them more problems than it does help them in the long run. So when you have a DBT program or you're using DBT, what you're doing is skills training groups. That's the #1 way that we teach skills, or we do the skill acquisition process with patients. And in there, we also help them build competence with their skills. So what we do at Willow is we have a skills training group that therapists lead, where they learn the skill. It's a very didactic and learning process, pencil, paper, those kinds of things. And then later in the evening, they have a skills group led by our line techs or mental health technicians, who we call coaches, where they actually practice the skill. So I might teach them self-soothe at 10 o'clock in the morning, and then at 6:45 or 7 or whatever, they're self-soothing with something at that point in the day. So we're learning skills, building competence, and we're doing all 4 modules: mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. Then we have coaching, okay? So coaching happens 24/7 in our facility, right? Someone starts to get emotional or runs out of a group, or can't stand the noise level in the cafeteria. A coach is going to approach them and say, hey, I noticed you seem a little upset. What's happening? How can I help you? What's going on, right? And so coaching also happens a lot in therapy. Anybody have a patient that just shuts down on them in the therapy session and won't talk? Or the person who's yelling and screaming and telling us we don't understand and we don't care, right? Or the borderline patient who's very proud to come in and show you their most recent cutting on their arms or their legs, right? So we do a lot of coaching in those sessions as well. So literally a patient can get coaching up to 24 hours a day from their therapist. And coaching is a 10-minute process. It should never be longer than 10 minutes if you're coaching effectively. And so I think we talk about that as well. So in individual therapy, that's where we set our treatment targets. And I don't want to get too much into that because I have a slide about it in a few minutes. And then that's where we work on motivation. And after they have some skills under their belt and some effectiveness with skills, that's when we actually can work on things like trauma, okay? And then in family therapy, we work on improving family functioning. We help families stop making it worse. We help families learn and practice skills as well. And mostly we help families learn validation. Validation is a huge component in DBT. And then the therapist consultation and shift report, we all increase our skills, right? We have our consultant, Dr. Alan Frizzetti, joins us in those consultation meetings. He's the one who's viewing our tapes. He's the one who gives probably the most harsh feedback at times, but the most valuable feedback as well. He really pushes us to grow. So it helps us increase motivation for therapists, and then we as therapists go to the shift changes for our mental health techs, and then we help them with their skills as coaches. So that is the view from 10,000 feet. So I talked a little bit about targets. DBT works on targets in a hierarchy. So the number one type of targets that we work on in DBT are life-interfering behaviors. Any behavior that could reasonably result in the death of someone is our number one target. And we don't move away from that target until there's some success in and some motivation to stop trying to kill ourselves, to stop self-harming, or perhaps using substances to the point where we have almost died, okay? And then the next, I was surprised by this when I first got trained in DBT, the next target is treatment-interfering behaviors. Because you can't have a life worth living if you die, so life-interfering behaviors makes a lot of sense, and you can't make a life worth living without therapy. So treatment-interfering behaviors is the next thing that we target in terms of DBT. And so life-interfering behavior are things like suicide attempts, suicide crisis behaviors, if you don't, I'm going to kill myself, those kinds of things. Deliberate self-harm, and any other imminent life-threatening behavior. And then serious treatment-interfering behavior is not showing up for session, avoidance during session. The patient who you really want to talk about, do a chain on, you know, what resulted in their last episode of self-harm, and they want to avoid it and tell you what a terrible therapist you are. Or maybe they want to avoid it and tell you what a wonderful therapist you are. Clearly, it's treatment interfering, either pole that they're on with that. So when they're not collaborating, when you have a group, if they're interfering with other patients, all those kinds of things are high on our targets, okay? And I like that because it's going to help them in the long run be more effective with people who aren't going to be nice to them even if they say fuck you, right? Then we move down into serious quality of life interfering behaviors. And by serious quality of life, that's severe co-occurring disorders, extreme living conditions, criminal behaviors, domestic violence, severe things that reach that level of egregiousness, right? Like, this is not sustainable at all. Those are all stage 1 targets. And the stage 1 in DBT lasts 1 to 2 years. 1 to 2 years on an outpatient basis for someone with the diagnosis of borderline personality disorder. Then in stage 2 is when we can work on things like trauma. We can work on other residual mental health disorders that are co-occurring for that patient. We can continue our work on emotion, how to deal with the different emotions that come up for our patients. And that's all stage 2. A little bit about manipulation. Anybody out here ever hear someone with borderline personality disorder or borderline traits called manipulative? Certainly the experience of these patients is that they are manipulated. We feel manipulated. And I just want to be the devil's advocate on this for a few minutes. The definition of manipulation is getting someone to do what you want them to do without them realizing they're being manipulated and with the least cost to yourself. So if I'm manipulating you by cutting my arm and oops, I mistakenly nick an artery, that's a pretty high cost to myself, right? So it doesn't fit our definition of manipulation, right? I agree that they want to get their needs met and they don't know how. And how sad is it that the best someone can come up with to get a valid need met is to cut their arm to get you to notice, right? How sad that that's the best that they could do, right? So we're gonna watch a little part of a video about this.
I remember one time when I was in 9th grade, actually, and I had finally made a friend. And this was like a friendship where we were spending time together, and I was so happy. I mean, it really, and my relationships with people tended to be so intense, and I didn't really know how to kind of just have casual friendships. I was like, you know, you're my best friend forever and ever, you know, and probably the 6 months, 8 months of our friendship, this young woman lost a lot of weight and went through this transformation. You know, her sort of moving up the social ladder and hanging out with the kids who were cooler and prettier and whatever. And when she did that, I found that I was unable to accept what she had done. I ended up sending her a letter written in my blood.
Writing a letter in your own blood is a beautiful example of communication of a desperate need, which would be very difficult for the other person to ignore.
This is a group of people who often need other people to regulate them.
The relationships that they form are often breathe life into them.
And therefore, if the people who are regulating them in some way are getting ready to leave them, it can feel like a life and death proposition.
Absences or separations from those relationships, once they're established, are catastrophic in their significance. Like I don't exist myself.
I'm not sure that people with borderline personality disorder know that they're being manipulative, but it comes across that way often to the people who are living with them or who are around them. Sometimes for the family members, it's almost like walking on eggshells. Sometimes living your life in what you think is a normal way is upsetting to them, so you stop doing that, and then you feel like that was their purpose all along.
People see the emotional sort of, I think there's a phrase, you know, I hate you, don't ever leave me. People tend to see it not as a medical condition, but as just somebody being difficult, dramatic, self-absorbed.
Can you fathom someone thinking that sending somebody a letter in blood is going to create an urge in them to approach them, right? So there's a couple things I wanted to highlight from this video. One of them is that one of the criteria for borderline personality disorder is this overwhelming sense of emptiness. And that's what Marsha Linehan was the lady on the tape, one of the ladies on the tape, talking. And that whole idea of I don't exist without your approval, or I don't exist without something outside of me telling me that I exist, right? So it's that's that profound sense of emptiness, right? I don't matter, I don't have any worth and value. And so to have a friend and then lose a friend, the best she could do, again, how sad is it, that the best she could think of was to write someone, not a letter, letters in blood, right? Saying, please don't leave me. Rather than just calling up and saying, hey, I miss you, want to hang out? You know, she doesn't have those skills. She didn't have those skills.